Hello, Dr. Freer. Are you able to hear me now?
I can hear you fine, Haley.
Okay, wonderful. I think we can finally get started. And again, apologies to everybody for technical delays. All right, so good afternoon, and thank you for joining the Los Angeles County Department of Public Health today, August 11th. We have Dr. Barbara Freer here, who is going to give us some remarks on COVID-19, and then we'll have our Chief Medical Officer, Dr. Rita Singh Hong, present on monkeypox. And after presenting, we'll take your questions. So to ask a question, remember, you just chat me, the host, or you can raise your hand icon. So Dr. Freer, whenever you're ready.
Thank you so much, and good afternoon. Thanks a lot. We're sorry for all of the delays. I'm going to give a COVID-19 status update for LA County, talk a little bit about safety at our schools, and then, as noted, we'll get an update on Mpox by Dr. Singhal, who, as you all know, is the Chief Medical Director here at the Department of Public Health. First slide, Haley, please. In the past week, we've had significant further declines in cases and a decline in hospital admissions. Haley, are you able to get the first slide up? Today we're
getting the slides up. Just one moment.
Today we're reporting 4,345 new cases with an average of slightly under 3,800 cases per day reported over the past week. This is a 22% decrease from the average of 4,900 cases per day that we reported last week. The number of COVID positive patients in LA County's 92 hospitals has declined after initially plateauing last week. And we're reporting 1,098 hospitalizations today. That's compared to 1,254 hospitalizations reported a week ago. Among those hospitalized who are infected with COVID, 43% are hospitalized with COVID-associated illness, 11% are in an ICU, and 6% are on a ventilator. The 7-day average test positivity rate decreased slightly this week, and it's currently just over 12%. We did report an average of 14 deaths per day over this past week. That's a small decrease from the average of about 16 or 17 deaths that we reported the prior week. Deaths always lag behind cases and hospitalizations, so we're relieved to see the declines in the case rates finally translate into decreases in reported deaths. It's continuing to take family members away from these deaths continue to take family members away from those who love them. We do recognize the heartache that's associated with these losses, and we send wishes for healing and peace to all who have lost a loved one. Haley, are we still having a problem with slides?
Sorry, unfortunately we are.
Are you able to fix it?
I'm working with the tech team to fix it right now.
Okay, I'm going to keep going just in the interest of time. This slide, if you could see it, has a green trend line that shows our cases. The last time we looked at it last week, you could see we had a pretty significant decline that continued this week, the 7-day average being at just around 3,800 cases a day. This is similar to what we reported back on May 23rd. And our daily hospital admissions also decreased this past week. The 7-day average number of daily admissions is now at 139. We were at about 147 a week ago. Modeling data from the California Department of Public Health does predict that we should see continued small declines in hospital admissions across the state during August. So we're hopeful that this sustained decline will become evident in our own data in the coming weeks. As we noted earlier, and if you could see on this slide, it would be our blue line. The 7-day average number of deaths reported daily has decreased slightly, but still remains elevated from where we were a few weeks ago. While we're greatly encouraged by the decline in cases, hospital admissions, and deaths, because viral transmission remains high, there are still thousands of new people each day who are infected and therefore capable of infecting others. Because we know that getting infected causes disruptions at the workplace and in the family, and for some, becoming infected can lead to debilitating illness, we advise caution and ongoing use of a layered approach for reducing the risk of exposure and preventing severe illness. All of the tools available help. Getting vaccinated and boosted reduces risk of severe illness, and testing before gathering, wearing masks when indoors, and staying home and away from others when sick reduces transmission. I do want to talk for a minute about the CDC's COVID-19 community levels framework that we're using to monitor strain on our healthcare system that's caused by COVID-19. The CDC's framework, as you all know, utilizes one case rate metric and two hospital-related metrics. The first metric is calculating our 7-day case rate. The CDC reported that today at 302 weekly cases per 100,000 people. That's a decrease from the 376 we reported a week ago. The first of the two hospital metrics in the 7-day is a 7-day total of new hospital admissions per 100,000. And today, CDC reported LA County's rate at 9.9 weekly hospital admissions per 100,000 people. That second hospital metric, the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients, that metric today for LA County is 6.5%. That's a decline from 7% that we reported from CDC last Thursday. As you all know, on July 14th, LA County did move from medium to high COVID community level in the CDC framework. According to the data that we saw this morning, the declines in the LA County hospital admission rate should drop us from the high to the medium community level today. So we're hopeful. We're looking at their own data tracker, and we're hoping that when we all see the posted framework updated later today, we will, as we anticipate, have entered back into the medium community level. I do also want to provide a quick update on the early alert signals. We've seen declines in 4 of the signals and a slight increase in 2 of the signals. We saw decreases in the percent of emergency department visits that are COVID related, in the case rate in the lowest income areas, in the number of new outbreaks open per week in skilled nursing facilities, and the number of worksite case clusters per week. There was a slight increase in new outbreaks per week in settings for people experiencing homelessness. We increased from 9 new outbreaks last week to 11 this week. Although this increase is, of course, of concern, we're hopeful that given the declines we're seeing across most of our other metrics, this may represent a small fluctuation and not an upward trend. There was also an increase in the percentage of specimens sequenced that were identified as being BA.5 or BA.4 subvariants of the Omicron variant. This is what we expected since the BA.5 subvariant in particular has been outcompeting our other variants. I'm going to review a couple of these signals in more detail. Starting with the Omicron variant, continuing to account for 100% of the sequenced specimens. The BA.5 subvariant of Omicron, if we had our table, those red sections, are predominating. And as of the week that ended July 23rd, BA.5 comprised 80% of all of our sequenced specimens. That was only a slight increase over the 78% that we saw last week. The CDC is estimating that across the country, as of the week that ended August 6th, BA.5 subvariant accounted for 87% of specimens. That also was a modest increase over the 85% they had reported from the week before. It's possible that these findings may be heralding a saturation of our population with this subvariant. The relative proportions of other key sublineages we've been tracking, including BA.2.12.1 and BA.4.6, held steady this past week. We didn't see any increases. BA.2.12.1 is at about 8%, and BA.4.6 is at about 1%. We've still only detected 2 cases of BA.2.75. That's that Omicron sublineage that we're watching based on what happened in other parts of the world. But again, no increases here at all. The past winter's Omicron surge was fueled by several subvariants and sublineages that arrived one after the other, including the BA.2 subvariant and its sublineage BA.2.12.1. The arrival of BA.4 and BA.5 subvariants further fueled this most recent summer surge. While we're carefully tracking BA.2.75, BA.4.6 closely, to date, they've remained relatively stable over the past several weeks, and we don't have any indication at the moment of a new variant that is rapidly spreading. This does give us hope that the recent decline in cases may continue for some weeks to come, recognizing that we cannot predict with certainty the future course of the SARS-CoV-2 mutations or when new variants of concern may emerge, or the behaviors that we all engage in that offer us some protections. As a reminder, essentially all of the currently circulating subvariants have an ability to cause repeat infections for those who've already had COVID. Each infection brings some risk of getting long COVID, and repeated infections may be associated with a higher risk of developing heart disease, lung disease, and other long-term health problems. Therefore, we continue to encourage people to reduce their risk of exposure wherever you can. If we were able to see this slide, we would be showing. Yep.
I apologize, just 1 second. I just want to flag for you and everybody else. I'm going to post the slides so they can be downloaded in the chat so media can follow along there. So I'm going to do that in just about a minute. So everybody should be able to have access to the slides in about 30 seconds.
Okay, thanks a million, Brett. And we apologize again. On this slide, which you'll have momentarily, you can see all 4 wastewater systems that we're monitoring for the concentration of SARS-CoV-2 virus. And we've seen steady declines in viral concentration across the board since mid-July. As a reminder, since the testing methods vary between the plants, we just compare the trends and not the absolute viral concentration values. Data from the 2 largest wastewater treatment plants, the Hyperion Water Reclamation Plant and the Joint Water Pollution Control Plant, the results we get from those 2 plants reflect what's happening for about 7.5 million people across LA County. The viral concentrations at Hyperion, which serves central and western portions of the county, showed a steady decline through the second half of July. We had a very small uptick this past week, but again, there's a lot of little fluctuations here. We anticipate that this is reflective of what we're seeing in our case data, which are steady declines across the county. Viral concentrations at the Joint Water Pollution Control Plant, which serves the southern and eastern portions of the county, also decreased throughout the second half of July, and we saw continued declines there this past week. The viral concentration data from the 2 smaller plants, Lancaster Water Reclamation Plant that serves people in Lancaster and Palmdale, and the Tapia Water Reclamation Facility run by Las Virgenes Municipal Water District, serving the people in Calabasas and the surrounding areas, also saw declines in their viral concentrations. A little bit of plateauing more recently at the Tapia plant in Calabasas. The wastewater data, we continue to look at it. It's a very helpful tool for monitoring viral transmissions in the community, and it does enhance our ability to see what our viral trends are. I'm now on a slide, if you're following on the slides, I think it's slide 7. And I want to really just spend a few minutes talking about sort of everybody heading back to school, how exciting it is. I want to start by applauding the administrators, our labor partners, the teachers, staff, students, and parents for their really outstanding efforts to create safety at schools. Yesterday, the LA County Public Health Department posted the guidance for schools, and it captures both required and recommended safety measures. I'm going to start with required actions. All schools are required to have a written COVID-19 containment, response, and control plan. The plan includes selecting a designated COVID-19 compliance team that's responsible for establishing the COVID-19 safety protocols at a school and ensuring that staff and students receive education about COVID-19 and the school's protocols. Schools are also required to have a plan for responding to every COVID case and for notifying close contacts. A contingency plan should include a way of managing any large-scale outbreaks, including a plan for a partial or full closure if that ever were to be needed. There are requirements that the school must follow as well related to masking. First, the school must offer medical masks and respirator masks to all staff and teachers. This is a requirement for all employers and workplaces, and it's required by both Cal OSHA and by LA County. Masks do remain an important layer of protection, and they're required to be worn at schools in certain situations. If the health officer order were to require universal indoor masking, that would be one situation where at schools, everybody would be required to adhere to universal indoor masking. Currently, there is no health officer order for universal indoor masking, and therefore indoor masking at schools remains strongly recommended. However, there are a few situations where people do need to wear their masks. Currently, if an infected staff member with COVID qualifies to return to work after day 5 of home isolation, the staff member must wear a highly protective mask around others through day 10. Anyone who's been exposed to someone with COVID needs to also mask indoors when around others for 10 days following their last exposure. In an outbreak situation at a school, the Department of Public Health may require additional masking at that school as the situation warrants. Schools also need to have a plan for assuring access to testing in response to illness at school or exposures to the virus on the campus. Schools are required to offer testing to their staff who've had school-based exposures, and they should be able to offer response testing for students who are symptomatic or close contacts to a confirmed case. Public Health is working closely with the LA County Office of Education to ensure that every school is connected to testing resources. While schools no longer need to report every positive case to the Department of Public Health, they are required to report to Public Health whenever they have 3 or more linked cases over a 14-day period. Public Health will work with the school to determine whether the cluster is an outbreak that will require a public health outbreak response. I'm going on to the next slide. There are a number of additional recommended safety measures that can be implemented at schools to enhance protections. These are all recommended measures. One very important strategy is increasing ventilation in indoor spaces as much as possible and reducing crowding. Schools can move certain activities or parts of activities outdoor when weather allows, where COVID risk, we all know, is lowest. Strategies for improving indoor ventilation include repairing or upgrading HVAC systems to allow for a higher level of air filtration, placing window fans blowing outward, or placing air cleaners in areas with poor ventilation. Schools can use the CDC's online interactive school ventilation tool to help them make good choices and decisions. I want to note that the California Department of Energy is currently offering a 3rd round of funding to public schools through a program called CalShape, which stands for the California Schools Healthy Air, Plumbing, and Efficiency Program. The CalShape ventilation program provides funding that can cover HVAC assessments, general maintenance and adjustment, filter replacement, and carbon dioxide monitor installations. Schools in underserved communities and those located near freeways or industrial facilities are prioritized. Public schools can learn more at energy.ca.gov, and they can search for CalShape. The application deadline for that program is October 31st, 2022. I also want to know that the federal government also has resources for schools to improve their ventilation as well. And the CDC has a good listing of those opportunities on their website. While viral transmission is high, indoor masking is still, as I stated, strongly recommended. Schools can choose to require masking in all or certain areas to increase safety. During times of very high community transmission, schools may consider, where they have resources, offering routine testing for all students and staff to identify asymptomatic individuals early to prevent spread. Schools have been offered resources to encourage students and staff to test either right before they return to school from the summer break or in the first few days of returning to school from the summer break. Students that are participating in certain extracurricular activities that are associated with elevated risk of viral spread, this includes medium and high contact indoor sports and performing arts, may want to test weekly, especially during times of high transmission. Again, this would help reduce viral spread. One sensible strategy for schools to consider is to offer daily health screening checks. These can be reminders for parents to check their child's health every morning before school, or this can be a physical health check that's performed prior to entry at the school. Next slide. Creating safety at schools works best when everyone can do their part. Parents and guardians and students need access to good information on how they can best support the school and county policies for minimizing threats associated with COVID-19. Vaccination does remain the most powerful tool available for preventing severe illness, both for adults and children. And while most children experience only mild illness, there are thousands who require hospitalizations and some who face longer-term illness associated with their COVID infection. Vaccination is free and available in hundreds of places throughout the county. Please call us at 833-540-0473, 7 days a week from 8 a.m. to 8:30 p.m. if you have any questions or concerns about vaccine safety. Our public health team is happy to answer your questions and to try to address your concerns. You can also visit our website at vaccinatelacounty.com to learn about vaccine schedules for children, as well as where they can be vaccinated. If your child is sick with symptoms similar to those associated with COVID, please get them tested. If they test positive, follow isolation instructions in order to keep them away from others while they're most contagious. Children with COVID must isolate at home for at least 5 days. If they have no fever, their symptoms are improving, and they test negative on day 5 or later, they may leave home isolation early. Everyone leaving isolation early should wear a well-fitting mask until day 11 of their isolation period. There's more information about how to isolate safely with COVID at ph.lacounty.gov/COVID isolation. Parents should also be prepared to test your child for COVID in certain circumstances, such as when they're sick, 3 to 5 days after they were exposed to someone else with COVID, and in other situations where you may need to see if they got infected. Testing children before and after traveling, before and after attending events or gatherings also remains important, especially if they'll be around individuals at higher risk. Always read the instructions that come with the test kit and store unused test kits in a cool, dry place. Many schools are going to be able to distribute test kits to their students for targeted testing at certain times of the year. And many families can also obtain test kits from their health plans or their insurance companies. Those test kits should be free, up to 8 tests per member per month. Many parents do ask about masking. We do strongly recommend indoor masking for everyone, including children, in all indoor locations where viral transmission is high, as it is right now. This includes indoors at schools. Everyone, including children, should mask around family members when they're sick with COVID and they're isolating at home. Children at school who have been exposed to a confirmed case do need to mask when indoors around others for 10 days after that exposure. This helps to layer in protection during the virus's incubation period. I'm going on to the next slide. This should be slide 10. In a moment, we're going to hear an update on monkeypox from Dr. Singhal. However, as we're talking about what parents should know as children head back to school, I wanted to talk for just a minute about rashes. There are many common rashes in children, and the risk of monkeypox in children is currently extremely low. However, parents should contact their child's pediatrician or medical provider if any new unexplained rash appears. The child should be kept at home and their rash is covered until the doctor is consulted. You should encourage children to avoid touching the rash as much as possible and help them practice good hand hygiene. As we start the school year, we're in a much better place than we were a year ago in this pandemic. We have vaccines available for all children ages 6 months and older. We have good access to therapeutics and testing and a wealth of knowledge about this virus. Our school districts have gained a great deal of experience and expertise in managing COVID risk on the campus. I want to thank all our partners and wish students, staff, and teachers a rewarding and productive year of teaching and learning. And now I'm going to turn it over to Dr. Singhal to give an update on Mpox. After that, of course, we're happy to answer your questions.
And just a flag for folks, sorry to interrupt, Dr. Singhal. I'm about to post the monkeypox slides in the chat, so folks have access to them shortly.
Thank you, Brett. Thank you, Dr. Fair. Happy to be here with you today to provide an update on monkeypox. So I'll be providing a situational update, the demographics and geographic profile of cases in LA County, updates on our vaccination efforts, and assessing risk for monkeypox. So going to the first slide, so a little bit on our situational update. So the number of monkeypox cases continues to rise around the world and here in the United States. As of August 10th, there are over 31,000 cases of monkeypox across more than 89 countries. This includes nearly 10,400 confirmed cases in the United States from 49 states and 1,892 cases in California. To date, there have been 738 cases of monkeypox identified in LA County, which is double the number of cases we had 12 days ago. Additionally, there have been 33 cases reported in Long Beach and 8 cases reported in Pasadena. The median age of monkeypox cases in LA County remains at 35 years of age, and we do now have 1 case in the younger than 18 years of age group, which is in addition to the pediatric case reported in Long Beach last week. Only about 30% of cases report domestic or international travel, indicating that the majority of cases are now from local transmission. There have been 15 hospitalizations among persons with monkeypox, most of which have been due to minor complications from monkeypox or for pain management. Internationally, there have been 4 deaths in countries outside of where it is endemic. However, there have been no deaths due to monkeypox in LA County or nationally. Going to the next slide. Public Health continues to track the demographic and geographic profile of monkeypox cases in LA County. This dashboard is live on our website and is updated every Friday. The profile of cases in LA County continues to align with what is being seen across the country and the world. As of August 5th, 99% of monkeypox cases in LA County reported being male, and over 85% reported their sexual orientation as gay or bisexual. Additionally, 38% of monkeypox cases were white, 34% Latinx, 11% Black, and 5% Asian. Going to the next slide. Geographically, just over half of our cases are in Service Planning Area 4, or the metro region, which is shown in purple on the map. 15% of cases are in Service Planning Area 2, or the San Fernando Valley, shown in blue. The remaining service planning areas have less than 10% of cases each, with SPA 1 and SPA 3 having the fewest cases. I want to emphasize that the risk of monkeypox in the general population remains low. Our public health community and field service teams continue to investigate cases and conduct contact tracing to provide resources, vaccine prophylaxis, and education, and to collect information so we can track how widespread the virus is in our community. So moving to the next slide, we'll now talk a little bit about vaccination. Public health is continuing to be aggressive in our vaccination efforts. As a reminder, the federal supply of the monkeypox vaccine remains limited. The public health priority is to administer a first dose of vaccine to as many people who are at higher risk for monkeypox as possible. And when vaccine supply improves, public health will make second doses available. To date, we have received over 43,000 doses of the Jynneos vaccine. This includes about 24,000 doses received initially and in phases 1 and 2, and about 19,000 doses received as part of tranche 1 of phase 3. Tranche 2 of phase 3 will be available to us to order next Monday, August 15th. This will be about 30% of our total phase 3 doses, or about 14,436 doses. The last tranche of phase 3 will be another 14,436 doses, which will be available to us once we've administered 90% of our doses received. Thus, we expect to receive nearly 29,000 additional doses later this month. I would like to address a new development regarding an alternate dosing regimen with the Jynneos vaccine. The White House announced earlier this week that FDA has approved under EUA, the Emergency Use Authorization, a dosing regimen that will use a smaller dose of the vaccine and be administered intradermally instead of subcutaneously. This approval was based on scientific evidence that this alternate regimen produces a similar immune response as the current vaccination approach. CDC has provided clinical considerations and guidance on the alternate regimen, and our community providers have begun to transition. For public health vaccination sites, we plan to transition by early next week. This alternate regimen has the potential to increase our vaccine dose amount by 5 times. We are estimating that with the increased dose capacity and the doses that we will receive in phase 3, we will be able to fully vaccinate with 2 doses as a 2-dose series, 85 to 90,000 people in LA County. This is still going to be only about half of what we see as the at-risk population for LA County based on the current profile of where we're seeing monkeypox. Moving to the next slide. This slide summarizes what our vaccine administration has been to date. So of the 43,290 doses received, as of 4 p.m. yesterday, nearly all doses have been distributed to vaccination sites across the county, from public health pods and clinics to community partners and hospitals, correctional health services, and our city public health departments. Of the over 42,000 doses distributed, 31,861 doses have been administered. About 2/3 of the vaccines administered were provided at public health locations, which were either our pods or the public health clinics. In addition to public health vaccination sites, we have community pods in West Hollywood and Silver Lake that began vaccinating last week, and we have 2 more pop-up sites that opened this week in Hollywood. Together, we expect about 3,000 doses to be administered at these locations by the end of this week. About 10,600 doses have been distributed to over 40 community clinic providers and hospitals, of which 68% of doses have been administered. We are continually working with these providers to address challenges, assess administration data, and redistribute doses accordingly. Our correctional health services continues to vaccinate those eligible in jails, and we have provided doses to both city health departments for vaccine administration within their jurisdiction. Last, we've allocated doses for persons experiencing homelessness and other vulnerable populations. More detail on how we're working with these groups will be provided a little later in this presentation. So overall, we've administered 74% of the doses LA County has received. The goal is to administer the majority of the remaining doses by this Sunday, holding only a small number for administration to newly identified high and intermediate risk contacts. So moving to the next slide, talk a little bit about vaccine eligibility. In an effort to simplify the eligibility for the monkeypox vaccine, Public Health changed and expanded the criteria last week. So monkeypox vaccine is now available to gay or bisexual men and transgender persons 18 years of age and older who had multiple or anonymous sex partners in the last 14 days, including engaging in survival and or transactional sex. Residents who met prior eligibility criteria are still eligible for vaccination. We are also prioritizing residents who are immunocompromised, including if they have advanced or uncontrolled HIV, as they may be at high risk for severe disease. Residents who do not have access to the internet or need assistance with vaccine access can call our public health call center at 833-540-0473. We have staff available 7 days a week from 8 a.m. to 8:30 p.m. in multiple languages. So moving to the next slide, to talk a little bit about our partner outreach. So over the course of the COVID-19 pandemic, public health formed strong partnerships with a number of community and faith-based organizations to share resources and information and to provide easy access to vaccine. And we are emulating that same model for the monkeypox response. We are holding telebriefing calls with these partners to provide a situational update on monkeypox and the vaccine effort and to answer any questions they may have. Public Health has nearly 100,000 printed materials about monkeypox that we are making available to our community and faith-based partners. We are also working with a number of partners to provide vaccines to the most vulnerable through mobile vaccine events and have already set aside doses for these events. Similarly, for the PEH population, we are also holding telebriefing calls with our providers and interim housing partners to provide the same information and resources. We've created a PEH-specific pocket card in English and Spanish that we are supplying to outreach teams. And finally, nearly 30 providers have committed to providing vaccines to PEH. These providers include federally qualified health centers, mobile vaccine teams, and other community partners. We expect to administer nearly 1,000 doses to this population over the next week. So moving to the next slide. I'm going to shift gears a little bit and talk a little bit about assessing risk for monkeypox. So I want to share some specifics on how residents can assess their risk based on actions that they may be taking. Monkeypox is primarily spread through skin-to-skin or close contact, but a lot of people are unsure of what exactly that means and what activities might lead to higher risk of transmission. Direct skin-to-skin contact, including sexual or close intimate contact, has been identified as the predominant type of exposure for persons with monkeypox in the United States during the current outbreak. Activities that have been found to be associated with a high risk of monkeypox virus spread include direct contact with monkeypox rash or scabs, sexual or intimate contact with someone who has lesions, close physical skin-to-skin contact such as hugging, kissing, cuddling with someone who has monkeypox, and sharing items such as bedding, towels, or clothing that have been used by someone with monkeypox and have not been cleaned. Activities that do not involve close or prolonged contact with someone with monkeypox have not been associated with monkeypox spread during the outbreak. Brief interactions such as casual conversations or walking by someone with monkeypox pose low risk. And the risk of spread is minimal from attending an event with fully clothed people, traveling with others on a plane or public transit, swimming in a pool, hot tub, or body of water, or going to a public setting such as a grocery store, restaurant, or to school. Moving to the next slide. Although the risk for monkeypox in LA County is low, cases are increasing, and anyone who has close or prolonged contact with someone with monkeypox symptoms could become infected. Prevention steps that can reduce the risk for infection include avoiding close contact with those that have monkeypox or a rash that looks like monkeypox, isolating those with monkeypox away from others who can be at risk for infection, and when interaction can't be avoided, wearing a well-fitting mask or respirator, and avoiding contact with materials like bedding and utensils that have been in contact with a person with monkeypox. And finally, of course, washing your hands often with soap and water or using an alcohol-based hand sanitizer. So moving to the last slide. So to close, I want to encourage residents to visit our website for up-to-date information and resources on monkeypox at ph.lacounty.gov/monkeypox. There, residents can sign up for our newsletter to receive updates on vaccine availability and additional information. We also encourage residents who do not have access to the internet and need information to call the Public Health Call Center at 833-540-0473. We have staff ready to take your call in multiple languages 7 days a week. Thank you. Happy to take.
Thanks so much, Dr. Singhal, and we'll open it for questions. And again, we're terribly sorry that it's been both delayed and less than ideal. So hopefully you were able to see the slides, and if not, we'll arrange to get them to people some other way. So, but happy to take questions. Haley, do you want to go ahead and open us up for questions?
Yes. Our first question will be from Ron Lin with Ron, you're
Hi.
unmuted. Go ahead.
Hi, doctors. Thanks so much for taking our questions. We really appreciate it. And we were able to see the slides. We have questions on polio, rapid tests, and monkeypox. So first, On polio, there's been some concern about the reemergence of polio for the first time in nearly a decade nationally. This was in New York State, not only in a person who developed paralysis, but it's also showing up in wastewater there in 2 counties. Some have expressed worry that lower childhood vaccination rates in general could risk reemergence of diseases like polio. Are you concerned about polio in LA County, and are you looking at starting polio monitoring efforts in wastewater? Second, on rapid tests. We've been hearing about situations in which, such as at UC San Francisco, officials have been telling employees, that the first couple of days of a rapid test may not show up as positive, and sometimes it can take as long as 5 days after symptoms begin for a rapid test to show up positive. Are you seeing the same thing here, and what advice can you give to people who are relying on rapid tests to figure out if, what they should do? And then finally, this is a question from my colleague Marissa Evans. There are concerns about whether equity problems are emerging again in terms of access to vaccine and treatment for monkeypox, similar to the beginnings of the HIV/AIDS epidemic. How are you and your team navigating concerns about potential racial disparities with access to monkeypox testing and vaccines? Thank you.
Yeah, thanks so much, Ron. All great questions. We're actually having a meeting today, right after this, to actually talk about polio monitoring in LA County and, the advantages, disadvantages. I think we all know that one of the issues we have with wastewater monitoring is where it covers large geographic areas. If you have very small numbers of cases, it could get lost in sort of the monitoring process because we're so big. So we're trying to figure out if there's an opportunity to do some targeted monitoring in some communities where we think there might be higher reason for concern, lower rates, for example, as you noted, around vaccinations. I do want to say that we're working really hard with all of our pediatric providers, family medicine providers, and our families to make sure that we're getting children back in for their routine vaccinations. Because just as you noted, we're talking about polio today, but it could be because of the sort of fall off in complete vaccinations for children throughout, during the pandemic. This could be any of a number of infectious diseases that in the past we really didn't worry that much about. So the big push right now is for us to make sure, again, families have good information, they have good access, here in LA County to providers. Our clinics also offer vaccinations as well, so that we're going ahead now that, things are all reopened and there's a lot less concern about being out and about going in for that routine care at providers, that people are going to take advantage of that. But we'll get back to you next week on sort of the monitoring plan. We do need to talk with some of our experts here, and then also we're working obviously closely with the state. In terms of the rapid test, we've noted before that for people who have symptoms and they use a rapid test, and the first 1 or 2 times they get a negative result, but they still have symptoms. The most important thing is if they're symptomatic, they should make sure that they're not exposing others. In a situation where you've had 2 rapid tests, at least 24 to 48 hours apart from each other. Some people are testing and saying they have 2 rapid tests, but to be honest, they tested at 10 o'clock in the morning and they tested at 2 o'clock in the afternoon. And then they're like, yeah, I'm testing negative. So these are tests that are spaced a little bit apart from each other. Those folks should get a PCR test. Now, there are other viruses that are circulating, other respiratory illness. We still have a little bit of flu circulating. So there are other reasons why people could have similar symptoms. But we do always encourage people, if you have symptoms of respiratory illness, if you have symptoms that you think may indicate that you might have COVID, please, please, please stay home. Use those rapid tests. They're generally fairly reliable, but if you still have symptoms and you're testing negative, go ahead, get a PCR test. And then, frankly, if you're still sick and that test is negative, you need to talk to your provider about what else you might be infected with. But no matter what you're infected with, until you're better, you should not expose others. And then the last question on equity on Mpox, I do want to state it's a huge consideration for us. And one reason why you see sort of in some ways a bifurcated approach in LA County is because we do want to attend to the equity issues right from the very beginning. So we have a call center now that makes it pretty easy for people who don't have computer access to be able to, get in and pre-register for those appointments. But one reason why we are creating a network with so many trusted community partners is because they can do outreach to their patients and to people in their community. And that might take a little longer for us to be able to reach everyone. But again, our provider network is both well trusted and well able to connect with some of those folks who may not be wanting to come into a public clinic or to come into a clinic where they don't know people. So again, the barriers are also reduced now. We're asking for less information as people go ahead and make those appointments. This is really an attestation process. People do need to show an identification. But again, as with COVID, there are no barriers based on immigration status or insurance status to getting vaccinated or tested or having access to therapeutics. And that holds true. I want to just say that access issue, remains important. And having different ways that people can come in and, both get good information and then, if appropriate, access a vaccine or an assessment, testing, and then for a smaller number of people, that treatment. We've got to make sure that that is also distributed everywhere and that people all will have easy access. Another reason for the call center 7 days a week so that we can make sure we're not missing folks. I do also want to note we have a couple of sort of independent outreach efforts. One is we are working with some community-based partners. They are not clinical partners, but they are partners that are sponsoring our pop-up mobile teams to be able to go into some communities where people may be more disconnected from healthcare resources. We're allowing our community partners to suggest where those mobile teams should be going, and then we're showing up again with vaccine for those who meet the eligibility criteria. And lastly, we have an independent effort that we discussed a little bit to really make sure that we're reaching those at high risk who are experiencing homelessness. I hope that's helpful. We continue to look at our data to try to determine that, if we are sort of reaching a diverse group of folks. I think it's a little bit hard on the denominator on this one. This is the eligibility criteria are for people who are engaging in higher risk activities, and there's no way for knowing for certain the distribution of where those people live and work. So we are relying heavily on this community partner network and making sure that access to all of the resources people need, information, vaccines, testing, and assessment, and for some therapeutic, if indicated, is easily available to everyone in the county. So I don't know, Dr. Singhal, if you wanted to add anything as well.
No, Dr. Fair, I think you've covered all of it. I was going to mention the kind of the robust engagement that we're doing with community-based organizations that are really representing these hard-to-reach populations, not only working with them on access to testing and vaccine, but also understanding what are the educational messages that we need to be using to make sure that those communities are well informed as well.
So I think we can go on to the next question, Haley.
Our next question comes from Julia Paskin with KPCC. Julia, you're unmuted. Go ahead.
Am I on?
Yes.
Oh, great. Sorry. First time using WebEx, so a little disoriented. Apologies. Thank you so much. Quick question for Director Ferrer. Just wanted to get your thoughts on the new CDC guidelines and specifically in terms of the rolling back test to stay and quarantine from exposure. And then a question also for Dr. Singhal. Can you speak to what we've heard discussed of increasing a public health risk when you overly characterize monkeypox as only impacting the LGBTQ+ community? Thank you both.
Yeah, thanks so much. So we of course just received the new guidance from CDC. I did have an opportunity to look at it quickly. I think we're pretty aligned already. We also, don't really require people to quarantine any longer. We do ask that they do 3 things, and we'll continue to emphasize that people need to do 3 things. One is, if you've got symptoms after you've had an exposure, please don't be out and about until you get tested and determine that you're not positive for COVID. So we really like to say, people who don't absolutely need to quarantine if they're asymptomatic. We also like people to know it's really important to test. And I think CDC says this as well. So, sometime around day 3 to day 5, CDC may be landing on day 5, but people should get tested. You've had an exposure, particularly with the variants that are circulating now. They're highly transmissible. So, go ahead, get that test. And then, similar to what CDC is noting, people during that 10-day incubation period of the virus should go ahead and wear a mask when they're indoors and around others. So I think we're fairly aligned. I will note that some of this is just practical because we can't do the contact tracing we used to do in the past. Everybody doesn't report their results to us. We don't have capacity to know who all the close contacts are. We really rely on cases identifying themselves to their close contacts, except in certain institutional situations. We just have to ask people to go ahead and be sensible about the fact that you've had an exposure. It is, potentially a 10-day incubation period. Take these 3 common sense steps. But again, I think we agree with CDC that if people can go ahead and follow those steps, it doesn't make sense for them to be staying home. But it is really, really important that people understand if you've got symptoms and you've had an exposure, you really do need to stay home, and you do need to get tested, and you do need to rule out that you are not positive with COVID. I'll turn it over to, and I think that's the big one. It was really around quarantining with an exposure. When I looked at it, I think we're fairly well aligned. CDC does really emphasize that local communities need to take a hard look at what's going on in their communities and their school guidance. They're really clear about making sure that schools aren't unintentionally leaving out people who are more vulnerable for risk of severe illness from being able to feel safe attending schools. So, varied interests, we need to work together. I think we put out sensible guidance that feels to me, sort of the first glance of what CDC put out is fairly well aligned with the recommendations coming out from the federal government. Dr. Singhal, do you want to go ahead on the monkeypox?
Sure. So I think this is a great question. So it's very important to understand that monkeypox is a disease that anyone can get. So it is not restricted to by gender or sexual orientation. We are in a situation right now that it is disproportionately impacting gay, bisexual men and other men that have sex with men. So, that is a community that we want to continue to support and make sure that we're providing messaging to and informing them of the risk. But at the same time, we are balancing that out with ensuring that there's no stigma. And we are likely going to see that there are going to be cases that are going to be kind of what we're calling leakage, where we'll start seeing some cases in other communities as well. But for us right now, it is really important that we are messaging correctly on what are the risks and, who and how that risk is, transmitted. It is basically through close contact, sexual contact. And that is something that we want to make sure that we're being very out front on. And this is something that we've heard from these communities. We have engaged with them where, they're our partners in the messaging that we're putting out. And we're working very closely with them, but at the same time, also making sure that we are messaging to the general public about what the risk is.
Yeah, thanks for that, Julia. We'll take the next question.
Next question is from Emily Alpert Reyes with the Los Angeles Times. Emily, you're unmuted. Go ahead.
Hi, thanks so much. Appreciate it. I have 3 questions related to monkeypox. So the first is, if a provider switches to the intradermal injections with the smaller dose, does that change the Department of Public Health guidance on holding off on scheduling second doses? Second of all, I wanted to ask whether the department is looking at expanding the availability of the Jynneos vaccine to sex workers who are not gay or bisexual men or transgender people, given the risk levels they face in their work? And then third, really simple one, if someone got a subcutaneous first dose of the Jynneos vaccine, can they get an intradermal second dose? Thanks so much.
Yeah, thanks so much. Rita, Dr. Singhal, can you go ahead?
Sure, no problem. So I'll take the first and the third together. So yeah, so with the intradermal dose, so we will actually be opening up for second doses as we transition into the intradermal or alternate regimen. So this will now expand, as you've heard, our vaccine dose amount by 5 times. And it is, we will be aligning with the CDC guidance that we do administer 2 doses, 28 days apart. And so with the new tranche 2 doses that will be arriving next week, we will begin to message out to those that received their first dose that they are now able to come in for their second dose. We can and will be using the intradermal dose regimen for the second doses. So that is part of the guidance that we received from CDC, that even if you did receive the sub-Q first dose, that the second dose can be given as intradermal. And just to make sure that we're clear, there are a couple of groups that cannot get the intradermal route, and that would be those that are less than 18 years of age and those that have a history of keloid or scar formation on their skin. So that is the current contraindications for the use of the intradermal route. So we will, those folks will continue to get sub-Q injections. Now, regarding sex workers and cisgender female risk, so we have been working very closely with this community and making sure that we're assessing their risk. They would be eligible for the vaccine if they were in a situation where they were a higher intermediate risk contact to a monkeypox case. And we are looking closely at whether we can expand our eligibility to include them. As you've seen our profile, the vast majority of cases that we are seeing in LA County, it remain among men. And so it's really something that we're watching closely, and we're hoping that as soon as we have more, vaccine where, we talked about how even with the current doses that we're getting through the end of the month, we can still only reach about half of our at-risk population, which is, focusing on gay and bisexual men. And so it's really, for us, we absolutely want to, open this up more if we could, but we also need to just kind of track very carefully who is the most at risk.
Thank you. We probably have time for one more question. I apologize. We started late. But both of us were due at a meeting at 3 o'clock, so we're going to go ahead and try to do one more question, and then please just contact our communications department. We'll get back to everyone.
Our last question will be from Marla Tejas with Fox 11. Marla, you're unmuted. Please go ahead.
Okay, thank you so much. Can you hear me okay?
Yep, we hear you great.
Okay, I was going to ask your reaction to the CDC relaxing its COVID-19 guidance, so thanks to Julie for doing that. Let me just follow up with my question last week about social media. Do you plan on letting the public comment again on the social media accounts that you have? And then what will it take to do that? And along those lines, you've voiced your concern about misinformation. And to that point, I do get a lot of questions from viewers about any number of your policies, and they want clarification. It's difficult to do that without the opportunity to ask follow-ups and in this Zoom format. So I'm curious if you're going to go back to holding these press conferences in person so that we have more of that ability to ask follow-ups.
Yeah. Oh, let me just take the latter. Yes, I mean, we would like to get back to in person. We're trying to figure out, a space that can accommodate us. Obviously we want to make sure we're not crowded, that we have good ventilation, that there's opportunities for us to continue to use slides. I know some of you have indicated that you like the fact that we are sharing slides. That's easy for us to communicate that information with those slides. So we're working on that, especially as our case rate comes down. Obviously the higher the community transmission is, the less inclined we all feel about getting together. But as we feel like we're on a significant decline right now, we'd like to go ahead and figure that out. But it might not start up, Marla, until sometime in the middle of September. That's really what we're aiming for. In terms of our social media accounts, feel free to get more detail from our team here. My understanding is anybody who wants to ask us a question can use our accounts now, the way they're set up, to send us those questions. You know, I don't know if what you're saying is while we're doing a presentation like this, while we're doing the briefing, or if what you're saying just in general to open up our accounts. What we're going to do is just, you know, take people's questions and get back to individual people. Our platforms were frankly being used in ways that we didn't think was appropriate, and we had a lot of complaints from folks about what was, you know, transpiring on some of our platforms. So for now, what we want to make sure we can do is just respond to everybody's questions, get back to people with answers, and engage the public in meaningful dialogue. This is never meant to, you know, really not be able to answer questions. I think we actually do a pretty good job on making ourselves available across the county to answer questions. So, but if what you're asking for, I think, is that all of our social media accounts going to be, you know, open for people to just comment to each other. We feel like people have lots of other places that they can use platforms if they want to talk to each other. We're concerned about responding to people who are looking to talk to us. And I think we have lots of ways that we're doing that. But again, if you think we don't, you know, please, you know, go ahead and contact our communications office so that we could look into it. But thanks for that. And we appreciate everyone. And we're really, really sorry for the delays. We're going to try to figure out what happened today. But we look forward to talking with you all again next week. Thanks a lot.
If we didn't get to your questions today, please email them to us at our media inbox. That's media@ph.lacounty.gov. Spanish remarks will begin in just a few moments, and the Spanish slides will be in the chat shortly.